Uh, Good morning. We will have a case discussion today. This will be presented by Dr. Alkama. She is a resident at CMRI, and Professor Prashanta Kumar Bhattacharya is a very good teacher. He is Professor Head of Surgery at Bakura Shumli Medical College. Dr. Bhattacharya will take us through the case. Okay, so I think we can start. Alkama, you can
Yes,
start,
sir.
please.
Yes, sir. So my patient, Mr. X, 56-year-old gentleman from Khidirpur, Kolkata, laborer by profession, presented to the surgery OPD with the chief complaint of lump in the left lower abdomen since 9 months, peradectal bleeding since 6 months, alteration of bowel habit for last 6 months, and pain abdomen since 3 years. Coming to the history of present illness, he was apparently normal before 9 months, following which he noticed a left lower abdomen lump, initially noticed of approximately size 6 into 5 centimeter, which was gradually increasing in size for the last 9 months. Patient also complained of alteration of bowel habit for the last 6 months. Previously, he used to pass stool daily, but for the last 6 months, he is complaining of increasing constipation. He is passing stool once in 2 to 3 days. He is also complaining of bleeding per rectum since 6 months, fresh blood mixed with stool of 1 to 2 episodes per month, which persists for 1 to 2 days, sometimes associated with mucus with loose stools. He is also complaining of dull aching pain in his left flank region for the past 3 months, which gets relieved after defecation. There was a history of anorexia and weight loss for the last 6 months. No history of fever, vomiting. There was no history of any urinary complaints. There was no history of any abdominal distension or pediledema or jaundice. There was no history of backache, bony pains. No history of cough, hemoptysis, dyspnea. No history of loss of consciousness, seizures, or altered sensorium. Past history, he is a known case of hypertension since 7 years and is on antihypertensive medications. There was no history of diabetes mellitus, bronchial asthma, coronary arterial disease, tuberculosis, or any contact with the close tubercular patient. No history of any previous surgeries. There was no history of similar complaints in the past. Coming to the family history, no significant family history of cancers in the first or the second degree relatives were seen. Personal history, he was married, having wife and 3 children at home. He consumes mixed diet. Sleep pattern was normal. There was no history of any addiction to smoking or gutka, anything. Allergy history, no history of any allergies to food and drug. Coming to the summary of my case, a 56-year-old gentleman came with the complaint of left lower abdomen lump, approximately 6 into 5 centimeter in size, which was gradually increasing since last 9 months. Patient also complained of alteration of bowel habit for last 6 months with increasing constipation, with frequency of stool passage. There was also history of blood per rectum since 6 months, fresh blood mixed with stools 1 to 2 episodes per month for 1 to 2 days, sometimes associated with mucus with stool, loose stools associated with dull aching pain in this left flank region for the last 3 months. There was history of anorexia and weight loss for the last 6 months.
Can you go back to the first slide? Let us take one slide after the other. Yeah. So at the end of this history, what do you think is your probable diagnosis? What are you dealing with?
Sir, this is mostly a pathology, mostly in the colon, mainly in the left part of the colon, descending colon sigmoid like this, because
Okay. Some like
yes.
colonic pathologies like?
Sir, as there is history of weight loss, I don't know whether it is significant weight loss because the patient was not giving me the exact data of the in kilograms. but most people probably with malignant etiology and
Okay. So
inflammatory
in that,
bowel disease.
yeah, malignant. So in that, so this lump can be explained because of what do you think is maybe a malignant pathology the patient is suffering from. What is the cause of this abdominal lump in such a patient usually? Is
So
it only
cause,
the tumor? Is it
sir,
the
maybe
tumor that is?
inflammatory, maybe but
No,
still it
supposing that it is a case of colonic cancer, what is the cause of this lump with which the patient usually presents to you? Is it only the tumor that is creating the lump or something else?
and sir, if sir mainly the momentum and all it gets adhered with the pathology.
Okay,
So
maybe some degree of addition of the surrounding structure, but mostly because of the pent up stool. Like you said, that the patient is having a history of altered bowel habits, gradually increasing constipation. So it is basically the pent up stool proximal to the lesion that is mostly responsible for that lump there. Okay.
yes,
Next, so this is a pain app. Next slide, please. Next slide. Yeah. Uh, Then you said about the alteration of bowel habits for the last 6 months. What alteration did he complain of?
sir, constipation, increasing
Only
constipation.
only constipation, or sometimes what is? Did he complain about spurious
No,
diarrhea?
sir, no, so no early morning spurious diarrhea. I was not complaining such like
What do you
that.
mean by spurious diarrhea?
Sir, when there is a growth proximally to that, there is accumulation of fecal matter, mainly liquid. So early in the morning, those
Mainly
liquid,
liquid,
um,
or is
liquid.
it pent up stool which ultimately on which the bacteria acts and makes it liquid,
Yes, sir. Yes,
isn't
sir.
it? And
Yes,
then
sir.
it patient passes
Is
out some amount of
the
liquid
loose
stool.
stools in the morning.
Mhm.
Yes, sir.
Okay. Uh, So that should be what do you mean by tenesmus? Sometimes a patient with rectosigmoid lesions can complain of tenesmus. Did you
Sir,
ask about that?
yes, sir. There was a no tenesmus. That is inadequate evacuation, feeling of evacuation of stool with discomfort. So there was no such history in the patient.
Okay, that is more common in rectal cancer.
Yes, sir.
Yeah, not only a sense of incomplete evacuation. Along with that, the patient passes what is called a bloody slime. That is blood-stained mucus along with freckles. Okay.
Okay.
Uh, then you said the patient complains of dull aching pain in the left flank.
Yes, sir.
Yeah, the pain usually, what is the cause of this pain usually? Or maybe, I mean, considering again that it may be a case of colonic cancer.
So generally, when there is like any such inflammatory reactions going on in that place, so in that case, mainly patient can suffer from dull aching intermittent pain.
Inflammatory reaction. Or is it because of the distension of the bowel? Because the bowel cannot, the patient cannot evacuate the
Yes,
content,
sir.
the gut gets distended and that causes pain, isn't it?
Yes, sir. That,
Or
yes,
it
sir.
may
That's
be in the later stage of the disease when there is inflammation, as you said, either some complications settles, some complications supervene over the main lesion, or there is infiltration into the surrounding structure that may cause the pain. But mostly in the initial stages, this pain is because of
distension
the
of the bowel.
distension of the gut, and usually that pain is not into in the region of the left flank, but more towards the lower abdomen. Why? It's more, think about the nerve, the autonomic supply. So left gut autonomic supply, it's from the region of what? Where from? This,
It will transfers, once it transfers colon, it is vagus nerve.
the sympathetic supply.
Sympathetic.
Usually for the right gut, the patient complains since it is from the sympathetic supply arises from the region of the superior mesenteric, the plexus around the superior mesenteric artery. And for left gut, it is the plexuses are associated with
Inferior
the
mesenteric artery.
yes, inferior mesenteric artery. So on the right side, usually the patient complains of pain in the upper part of the abdomen, while for the left,
Lower part.
for the left gut, yeah, mostly towards the lower part, infra-umbilical region. Next slide, please. Um, you had asked about some urinary complaints. What vomiting spelling is wrong, by the way. This is a very common mistake. What complaint can you expect in such patients?
Sir, urinary complaints are increased frequency of micturition.
Increased frequency of maturation, right?
So there is irritation of the bladder.
Now
Because,
you have asked, like for example, you have asked about cough, hemoptysis. These
yes,
are all, I mean,
Metas
complaints. Yeah, metastatic complaints because of metastasis.
yes.
Similarly, when you have
This is
asked
a
about the urinary,
local
yeah, you have asked about the
regional
urinary.
infiltration.
Yes, it may cause what? What can it cause? That particular lesion there can cause.
So irritation and compression of the bladder.
No, it can cause infiltration into the bladder itself, and
Yes,
patient will complain of pneumaturia, isn't it? Patient will complain of passage of flatus along with the urine, and of course feculent urine as well. Understood?
Yes, sir.
So that is one of the complaints. Just you have asked about the metastatic complaints. What are the local complaints that such patients can present with? And similarly, you should be aware of those symptomatology.
Sir, I cannot get you, sir.
What are the local complaints, complications that the patient can land up with in a patient with left-sided colonic growth, which you should be aware about? Like, for example, one is this urinary complaint.
Yes, sir.
Other? There can be perforations also, isn't it?
Yes, sir. Obstruction, perforation, peritonitis.
Those
bleeding.
complaints. The bleeding, very good. Bleeding. Fistula formations. Okay, very good. What does this pedal edema indicate? Abdominal distension and pedal edema. What is the importance of this?
Sir, when the size of the lump is increasing, it is getting compression of the lymphatics.
So one cause of abdominal distension is intestinal obstruction, gaseous distension. Yes, another cause of abdominal distension associated with these advanced cases may present with ascites because of peritoneal dissemination of malignancy. Pedal edema is maybe because of mostly because of hypoproteinemia, which may be associated with this because the patients are already anorexic. The appetite is not that good, and overall patient is having a malignant condition. So hypoproteinemia, the pedal edema is a reflection of the underlying hypoproteinemia. Next slide, please. You have asked about previous history of surgery. What surgeries are you concerned about mostly?
Sir, history of surgery, sir, previously, like any surgery for polyp or any pathology in the gut for which surgery has been undertaken previously.
Very good. Any other surgeries that you know of which can predispose an individual to develop colonic malignancy? I mean, which has been proven to have some relationship with colonic malignancy, some surgeries in the past. What you said is right. Previous history, maybe previous history of colonic surgery itself. Maybe patient had it's a recurrent. Yes, patient might have undergone treatment for polyps previously, but some other. So ureterosigmoidostomy is one of the surgeries which can predispose an
high
individual.
malignancy chances.
Similarly, even one of the common operations that we do, cholecystectomy, does it have any relationship with colonic carcinoma?
Yes, sir. Yes, sir.
It
I
has.
studied. Yes, sir.
Yeah, you have studied.
Yes, sir. These 2 years retrosigmoidectomy and post-cholecystectomy.
But cholecystectomy usually associated more with the right-sided colonic cancer rather than left-sided colonic cancer because of why does cholecystectomy predispose an individual to colonic cancer?
Sir, that.
Any idea?
No.
Huh?
No, sir.
You don't know. Okay. So it is because of increased delivery of the bile acids directly into the colon, and bile acid is supposed to be a carcinogen. It can directly act on the colonic mucosa and may give rise to development of colonic malignancy. Family history, you have what family, what are you concerned
Sir,
about regarding?
any history of familial adenosis polyposis or HNPCC related carcinoma in first or
Like,
second degree relative?
like HNPCC related carcinoma, like?
HNPCC, sir, colonic and extracolonic cancers, endometrial cancer, stomach cancer, ovarian cancer, breast cancers.
Very good. And urinary tract transition cell carcinomas that are also part of this. Sorry, part of this HNPCC familial carcinoma syndrome, as it is called, isn't it? Cancer family syndrome. Next slide. Next slide. Personal history. You asked about some consume mixed diet. What type of diet again is has got a relationship with this particular disease?
Mainly high fiber diet has a protective role in colonic carcinoma, and mainly the non-vegetarian red meat, spice, non spice and red meat, those have increased.
Spice, nothing to do with spice. It is a diet which is rich in fat and red meat. Red meat lead to
increase
nitrosamine compound, which is
incidence.
supposed to be a carcinogen. And how does fat rich diet predispose an individual? It basically favors the growth of a particular type of bacterial flora, which again causes the degradation of the bile acids into the carcinogens. Okay, that's how the fat rich diet is responsible. Has been proven to be responsible for increasing of gastric line. How does high fiber diet on the flip side prevents? How does it prevent?
Okay.
Yeah, how does it lowers the incidence?
Sir, it increases the amount of bulk stool and
reducing the
transit
exposure
time with the gut flora.
Yes, decreases the transit time, thereby reducing the exposure of the colonic mucosa to the local fecal carcinogens.
Yes,
Any other protective factors that you are aware of, which gives some amount of protection, which has been proven to, other than high fiber diet?
Any drug?
Drugs? Any drugs? Sir is asking you.
Protective.
Yes. Calcium carbonate has been proven to be one of the drugs which can protect because it again absorbs those bile acid. Okay. Other than that, beta carotene, then vitamin C, E, and all those things.
Aspirin
Yes.
also.
Aspirin, low dose aspirin. Yes. Okay. Next. Sir, any other question from this?
Actually, I would emphasize other students to see her presentation. That what a presentation should be. She has given clearly the symptoms in chief complaint and spent one paragraph for each of the complaints. That is the ideal way of elaborating history of present illness. And then after you have done that, you should go to the other GI symptoms, other systemic symptoms. That covers everything. So in the summary, you written anorexia and weight loss and add one line. There is no symptoms suggestive of distant metastasis because you have described in the history of symptoms. So these are not there. So need not repeat the whole thing. Just write one line. There is no other symptom suggestive of distant metastasis. Otherwise, your presentation is very good. This part of the history is good, and you have answered well. The question Dr. Bhattacharya is taking it through. So this should be the ideal way of presenting a case. Okay, we can pass on to the examination. Next slide. Yeah.
Coming to the general survey, patient was examined in a well-lit room after taking proper consent with adequate exposure. Patient is conscious, alert, cooperative, well-oriented to time, place, person. Patient was averagely built, well-nourished, well-hydrated. BMI 23.2, ECOG score 1, pallor present, no icterus, cyanosis, clubbing, no lymphadenopathy, pedal edema was present, no fullness in supraclavicular fossa. Vitals, uh, heart rate 86 per minute, regular in radial artery, blood pressure 130 by 70 millimeter of Hg in right arm supine position, temperature 98.6 degree Fahrenheit, respiratory rate 18 per minute.
This pedal edema you talked about here, is it bilateral or unilateral?
Sir, bilateral.
Bilateral pedal. What is the difference between, had the pedal edema been unilateral as against bilateral, what, how would you interpret these two findings? Like,
Sir, in my case, there was no pedal edema.
Oh, no pedal edema.
No
Okay, okay.
pedal
Oh, I thought. Okay. Now, I just to ask you this question: had there been a
Yes,
unilateral pedal edema in this patient as against bilateral pedal edema, what would you have thought?
So compression of the lymphatics in that side, unilateral. So
Lymphatics or venous?
venous, yes,
Venous return. Yes.
yes.
And bilateral will go more in favor of a
Hyperproteinemia,
poor. Yes.
the
Yes.
generalized condition.
Okay. Next slide.
Of systemic cause.
Yes.
Systemic cause. Yes.
Per abdomen examination on inspection, abdomen is flat, umbilicus central, visible fullness in left lumbar region. On leg rising test, fullness in the left lumbar region appears less prominent. Abdomen.
This word, just I'm interrupting you. The word is not rising. Okay, it is raising. You raise your leg. Okay.
Yes, yes.
Huh? Leg
Yes,
raising test. You ask the patient to raise the leg. Huh? Not rise.
Okay.
Sun rises or you rise up from bed, but huh? Okay, next.
In fullness in left lumbar region appears less prominent. Abdomen is moving normally with respiration. No visible scar, sinuses, peristalsis. Hernial sites and external genitalia seems to be normal. On palpation, there was no local rise of temperature or tenderness. A lump is palpable in the left lumbar region, extending into umbilicus and left iliac fossa. Size was 10 into 9 centimeter. Shape was globular, firm in consistency, smooth margin, smooth surface. It was non-tender. Margin was rounded. No mobility with respiration, but the lump is slightly mobile from side to side and up and down position. No evidence of any other organomegaly. On percussion, there was no evidence of any free fluid in the abdomen. On auscultation, there was normal bowel sounds heard. Per rectal examination, finger gloves stained with blood mixed with mucus, no growth palpable, no deposits palpable. Next slide. Summary. A 56-year-old gentleman came with the...
You missed systemic examination. That should be there. Okay.
Yes, sir. Yes, sir.
This slide should be systemic examination. Okay, carry on.
Yes. A 56-year-old gentleman came with the complaint of left lower abdomen lump, approximately 6 into 5 centimeter in size, gradually increasing for last 9 months. Patient also complained of alteration of bowel habit for the last 6 months with increasing constipation associated with bleeding per rectum since 6 months, sometimes associated with mucus with loose stools, associated with dull aching pain in his left flank for the last 3 months, associated with history of anorexia and weight loss for the last 6 months. There was no history of any distant metastasis. On examination, patient was pallor, and on abdominal examination, it was an intra-abdominal lump was palpable in the left lumbar region, extending into the umbilicus and left iliac fossa, which was sized approximately 10 into 9 centimeter, globular in shape, firm in consistency, smooth surface, rounded margin, not moving with respiration. On per rectal examination, finger glove stained with blood mixed with mucus. So my provisional diagnosis, he is a 56-year-old gentleman. Is a case of left colon pathology, most probably of malignant origin, that is carcinoma of descending colon.
Okay, go back to your abdominal examination. Abdomen is flat means what do you mean? Scaphoid?
No, sir, he was not that thin patient.
No,
And
then
not that person.
so
Sir, I will put
you mean to say
scale.
that the shape of the abdomen is normal? It is neither neither distended nor scaphoid, isn't it?
Yes, sir.
Okay,
Say shape is normal.
normal. So flat is something I don't know. It's not quite right.
Okay.
Umbilicus is central. What changes can you expect in the umbilicus in a patient like with colonic cancer?
If the lump is big in size, it can evert the umbilicus outward, or in case of
Evert.
ascites and all,
Hmm.
evert outward.
In case of ascites, what will be the change? Okay,
There will be
it may get
outward and downward displacement.
is the disposition, if you think about the disposition of the umbilicus, what changes take place in the disposition in a patient with abdominal distension due to gaseous distension, colonic all right, gaseous distension as against distension of the abdomen due to fluid. Understood my question?
Yes, sir.
The
Sir, in
shape
case
of
of ascites and
yes,
fluid
ascites,
distension, there will be the umbilicus will be everted and
it may be everted if
thin.
it will be a transverse slit. It becomes transverse as against an gaseous distension. It becomes longitudinal. Okay, vertical one. Yeah. Then
Have you examined the renal angle area?
yeah, that's what I was
Yeah.
trying to. Yeah, you
Yes.
have not even no. Go to the next slide. I was looking for that only. Regarding this 10 into 9 centimeter again, as I was telling you, if a lump is so big, it is unlikely that the malignant growth has become such a big of such a big size, isn't it? It is mostly because of the associated pent-up stool. Yeah, and in that cases, the findings would be somewhat a little bit different. Like, for example, the surface will not be smooth. It will be somewhat irregular because of all pent-up stool. Margins, as you said, it is absolutely rounded, maybe a bit ill-defined. And then you have not mentioned about, go to the next slide, whether the lump is bimanually, no, the other slide, yes.
What do you expect? Do you think this lump should be bimanually palpable?
Yes, bimanually palpable, because you said the lump is in the lumbar.
Is this lump bimanually palpable? It should be because you are saying the lump size, and it's not that always kidney is bimanually palpable. A descending colon mass, which is a retroperitoneal mass,
can also be bimanually
large size, may be bimanually palpable. You did not go for palatability because lump is bulging the anterabdominal wall. So there is no question of saying palatability, but these are the lump which can be bimanually palpable. But with a difference that if you ask the patient to sit down, the renal angles may not be full. Unless it pushes the kidney outward, the renal angle may not be full. But this lump may be jolly well bimanually palpable. You have to mention that at least. Because you have all the telltale signs of GI pathology. Otherwise, if you are not at the telltale signs and symptoms GI pathology, this is the ideal case for DD with a kidney lump. The location of the lump, the progression of the lump. Okay, but you have other symptoms which points more towards a GI pathology.
Yes, sir.
Yeah. Okay. Next. So you said it's a case of carcinoma. What are the other possibilities that you are that that you can think about in this particular case?
An inflammatory bowel disease, ulcerative colitis, Crohn's colitis, infectious colitis. There is no history of radiation. Radiation colitis can also, but in my patient, there is no history of any radiation.
Apart from Crohn's and ulcerative colitis, any other specific infection?
Infectious colitis.
What infectious colitis?
No, what infection?
There are two types. One is non-specific and specific infection. I mean tuberculosis. You should
Tubercular.
tuberculosis may have identical presentation. So it should be specifically told about a granuloma may form in tuberculosis.
Yes, sir. Yes.
Okay. So it's not just infectious colitis like a bacterial infection, unless it is anything else which can present with a chronic mass with some pain symptoms. Not very common in our country, but gradually find more and more such patients now.
Chronic mass and
Chronic mass, pain.
On history of long constipation.
irritable. No, it will not cause any lump.
This is chronic diverticulitis.
Diverticulitis,
and that diverticulitis has got a inflammatory change, and then it can cause a leak and then form a pericardic abscess also.
Yes, sir.
Okay, so these are not very common in our country, but still it should be a clinical possibility.
One of the differential diagnosis.
Yes, sir. The patient is complaining of bleeding per rectum. Yes, sir.
And you should also, I think, mention as in the differential diagnosis, one or two other things, like for example, it may be a GIST also. Possibility.
GIST, colon.
Yes, it may be a lymphoma also.
Lymphoma.
Okay,
Yes, sir.
GI lymphoma. These may be other possibilities. Okay, other than only carcinoma, as you said. Okay.
So confine your diagnosis to the presentation. Don't put something very unusual diagnosis is not fitting with your presentation and your findings. Okay, these are the points we mentioned, and Dr. Bhattacharya mentioned is more likely to present in the similar way. So don't put a diagnosis of retroperitoneal sarcoma in this patient.
No, sir.
Because patient has all the telltale features of a
GI symptoms I'm having.
How do you want to
justify the diagnosis of malignancy in this patient?
Sir, from clinical feature and history taking. Yes. Points in history. The patient is complaining of lump. Patient is complaining of bleeding per rectum. Yes, sir. Elderly male patient. Elderly male.
Left
yes, sir.
Is more common in male or females?
Left colon carcinoma. Sir, exactly, I don't know.
It's more common in gentlemen. It's more common in males. Right colon carcinoma is more common in females.
Females.
Okay, so is elderly gentleman, that is 1 point in favor. And that is a very short history. All history is spanning between 6 to 9 months.
6 to 9 months, yes,
so
sir.
it's a short history. And then what in history suggests is malignancy?
Lump increasing in size in a small span of time. And he's also giving history of weight loss. So this is mostly a malignant pathology.
On examination, how did you find to say it's malignancy?
So the lump size is bigger size. So and increasing rapidly.
I'm talking of signs. Large lump with
clinical findings.
Anemia.
Firm in fill.
Yes, a firm consistency.
Okay. Anemia, because in benign disease you may have anemia because of bleed.
Yes, sir.
Okay, okay, carry on. Dr. Bhattacharya, please.
So how do you want to work up this patient?
Sir, I will do diagnosis to confirm my disease, stage the disease, and investigation to plan my treatment.
Yeah, what
so to confirm my disease, I will like to do colonoscopy in biopsy.
Okay. Colonoscopy.
Yes, sir.
It's a left lower abdominal lump. You need not. You can do even a flexible sigmoidoscope, or for that matter, even that can suffice. But still, would you like to do a colonoscopy?
Yes, sir. I would like to do a colonoscopy till cecum.
Why?
To see, it will give me the scenario of the whole colon to see any
Yes.
synchronous lesion present in
Very.
the colon.
What is the length of the colonoscope?
Colonoscope length 30 centimeter.
160. 160. What is the length of large gut?
Large gut 30.
Large gut is around 150 centimeter, and a
150.
one colonoscope is
Large
160 centimeter. So you can just reach up to the terminal colon also with the help of a colonoscope. Yes, you must try to do a colonoscopy to assess the full length of the colon to rule out any synchronous lesion or polyps, isn't it? So in case
Yes.
you find that the lesion is very tight and you cannot negotiate the colonoscope, what other options do you have?
If
As far as
not,
assessing the rest of the colon is concerned, you have taken a biopsy and everything is all right, but you couldn't negotiate that structure's growth. You couldn't
yes.
assess, yeah, because your plan of treatment will vary as to according to whether the right colon is normal or it is bearing some polyps and other things, isn't it? Or in a synchronous
Yes,
lesion.
sir.
So how can you assess that part of it?
Then, sir, I will do
Virtual
CT scan
colonoscopy?
of the abdomen.
Now, what is virtual
Uh,
colonoscopy?
va- yes, sir. Virtual colonoscopy. It is 3D 3D colonoscopy in which there is a CT
3D
scan cut is done.
yeah, reconstruction. It is basically a spiral CT with 3D reconstruction,
Yes.
isn't it?
CT colography. Or
CT
MR
colography.
CT is a
colography.
CT scan. Yes, yes, sir.
Yeah.
So, but the disadvantage is that you cannot take any. You can assess. You can
Biopsy.
have a You cannot take a biopsy. It is much more costly. Okay. Any what other investigations you'd like to do? That is about the confirmation. Next, others.
Staging the disease.
Mhm.
I will like to do chest X-ray, LFT, USG.
Investigation. Chest X is not a staging investigation. Don't say.
Sir, initially we can do chest X-ray.
If you say
No.
No.
staging
Okay,
is
then
staging,
CT
you
scan
cannot
of
say chest.
thorax.
Yes. First
Okay,
talk
CT
of
scan
local.
of thorax.
First talk of local growth.
Local growth. Na? CT scan.
CT scan of the abdomen first.
Okay, sir.
CT abdomen for assessing local growth and the other distance between the abdomen.
Yes, sir.
And then talk of CT thorax. Don't say CT X-ray chest for assessing metastasis. You can have chest X-ray for other purposes, but for staging of the disease, you need a CT thorax.
CT thorax, CT abdomen. And I will like to do CEA.
How CT gives you a local staging?
Local staging, sir, it tells us about nodes, and it tells about it tells us about the ascites, any liver mets,
T staging.
peritoneum. T staging.
CT scan.
T staging in CT scan. Sir, thickness, bowel wall growth.
Involvement of the bowel layers. Because
Bowel layer
in GI
thickness.
malignancy, we don't talk of the tumor. It is the depth of invasion in the gut
Yes,
wall.
sir.
So if you say such a large lesion, it is likely that it is a transmural involvement. Unless there is transmural, you won't find such large lumps. So that depends on the depth of invasion in the gut wall. That is how you make a T assessment of the tumor in.
Sir, but in like CT scan, the wall, gut wall, and all the things can be seen.
Yeah, why not? You can see whether it has infiltrated throughout the gut wall. It has involved even structures or not.
Grossly it can be like within it is lumen or it is abutting the lumen. That can be
It can go
seen.
outside the lumen also. You can
Yeah.
diagnose even T4 lesions. So CT is a good investigation even for CS stomach and the colon. CT is an investigation which will give you T staging, number one.
T staging. Okay.
Then it can give you N staging. You can see the
N staging, yes, sir.
It can show you the liver mets. You can see the
yes,
other
liver
peritoneal
ascites, peritoneal mets.
Okay,
Yes,
so
sir.
CT is good for T, N, and M staging in the abdomen itself.
So, CT scan. Now, with all these investigations, and you have done a CEA also. What is the reason of doing a CEA?
Sir, CEA, it tells about firstly the prognosis of the disease. When the
Yes.
CEA is more than 5 nanogram per radial, then it suggests that
Okay,
disease
very
is
good.
having poor prognosis. And it also
Very
tells
nice.
about the completeness, like before doing the CEA, before surgery, that gives the baseline value. And after the surgery,
Help
when
you in
it
following up the patient.
following up, yes, sir. And
So
if it
you
is not
talked to,
coming down, that means there is a incompleteness of the surgery, whether
very
maybe primary or metastatic. And in the follow up, if it is not decreasing, means again, if it has decreased and again increasing, means some recurrence of the.
okay. So you talked about prognosis. When you talked about prognosis, what are the other features which suggest, I mean, which gives you an idea about the prognosis of the disease?
Sir, and involvement of the nodal status, then
Okay.
depth of invasion, as sir has said, then distant
Depth of invasion.
metastasis.
Very good. Hmm.
Yes, sir. And distant metastasis, if it is there, then it gives a poor
Medical
prognosis.
oncologists now will ask for some more studies on the biopsy specimen. Medical oncologists now are fond of asking for more.
MIS, sir.
Yes. What is that?
Yes.
MIS, my MSI.
MS, microsatellite instability.
Yes. What else? Because
And
they are all
MLL.
very important markers, which number one
Yes,
predict prognosis and also helps for your planning of therapy.
yes, sir.
What else?
Sir,
MSI.
MSH,
What other DEXA
MSH,
studies? Very important for
MSH.
chronic carcinomas.
Yes, sir. Sir,
KRAS,
MSH.
MMR. MMR. Have you heard about
M.
MMR?
MMR, KRAS,
No, sir.
BRAF
Yes,
mutation.
yes, sir. BRAF, yes, sir.
So there are a lot of others. I'm not remembering everything, but at least these common things you should be.
What is MSI, as sir told you?
Sir, microsatellite instability.
What do you mean by microsatellite? What are
Sir,
microsatellites?
sir, exactly, I don't know, but like it tells about in the cell cycle there
No,
is
no. These are
something.
basically microsatellites are repeat sequences of DNA. Okay. Now, in case when you find either very long or very short microsatellites, that is called microsatellite instability, MSI.
Yes, sir.
Okay.
Exons, some exonic, like that.
These are
Oh,
change in amino acid sequence also.
yeah.
Yes, sir.
All right. Next, you have done your workup. You have confirmed your diagnosis. What it's a case of left-sided, left descending colon growth. What
Yes,
should
sir.
be and it is operable.
Yes, sir.
So what should be your how would you now finally put up the case for surgery, and what plan of surgery do you have in your mind?
So initially, I will do some pre-anesthetic checkups, routine investigations, complete blood count, hemoglobin, TCDC, urea creatinine, LFT, ECG, X-ray, chest X-ray, etc. And the patient is fit for surgery, then I will do some.
If you find that the patient is having suffering from hypoalbuminemia, then you
Yes,
have to
sir.
correct the
Preoperative. Yes, sir.
correct
Preoperative. Yes, sir. Hydration of the
correction of
patient.
those.
Hydration of the patient, proper nutrition, anemia, is as anemia, then blood transfusion. If it is hyperproteinemia, then we have to give a proper protein rich diet and all. Then I will give some antibiotic prophylaxis, and then I will prepare the bowel for surgery.
Okay. And before
And
that,
for
would
this,
you explain the process to the patient or what you are planning to do to the patient?
yes, sir. Yes, sir. Exactly. Obviously, I will explain all the things
And
with my patient.
if
I
it
give
is
the
obvious,
alternatives.
don't say it is obvious. You have to say in your examination, I have to explain the entire procedure to the patient, patient's relative, and especially I have to take a consent for
Consent. Yes, sir.
what consent?
Sir,
Special.
special consent. Consent for all complication, systemic related complication, anesthesia related complication, and
Yeah,
then
those are
consent for
routine.
stoma.
Those are routine. Other than yeah, bolo.
Consent for
ठीक है.
stoma, sir.
Stoma, right? Stoma consent.
Yes,
If
sir.
required, you have to.
Hmm.
If you have the facility of a stoma therapist, you have to consult with them also so that you can fix up the site of the stoma pre-operatively, and then you finally
Proceed
As you
first.
said, proceed with the bowel preparation. How do you like to do the bowel preparation?
Sir, I will
Hello.
ask my patient for 24-hour liquid diet, and then before the surgery evening, I will give peg leg preparation to the patient, so that all the bowel is not loaded with stool. It gets all evacuated for the
So
clean surgery next.
do you like mechanical bowel preparation?
So
Or
nowadays,
what?
actually, in ERAS protocol, according to ERAS protocol, mechanical bowel preparation is not recommended. But
Why it is not recommended? You get a very good bowel preparation, by the way, by mechanical bowel preparation, but still it is not recommended. Why? It has been
sir,
found to.
seedling, if there is any growth, there will be seedling of the growth.
No. It has been found to be related with some degree of increased incidence of anastomotic leak. It
Yeah,
causes
understand.
bowel wall edema. It causes a little bit of bowel wall edema because of these aggressive action of these mechanical bowel the products for preparation. So, and that edema can be responsible for later on development of this anastomotic leak, wound infection. These are more with
Okay, sir.
mechanical bowel preparation. Now, what surgery would you plan in your case?
So in this case, I will plan for left
Alkama.
hemicolect. Yes, sir.
Sir is asking something.
In Indian population, you'll find there are a lot of center. They are saying that they are doing some sort of bowel preparation because in our patient population, the stool bulk is quite high.
Yes,
So
sir.
although it is not being
Not
accepted, but
recommended
there
in
are some.
ERAS, but we do, sir.
Yeah.
In our institute
So
also we do.
there is a trend now towards having bowel preparation or at least a limited bowel preparation. Okay, so
Yes.
what is the plan? What should be the rational surgical treatment for a patient having a descending colon growth? What should be the optimal surgical treatment?
So left hemicolectomy.
Good. Left hemicolectomy. Standard operation, left
Yes.
hemicolectomy.
So,
What
what do
else?
you mean by that? How much
So
you?
removal
What?
of the distal 1/3 of the transverse colon, descending colon, and sigmoid.
Just left 1/3 of the transverse colon.
Left 1/3 of the transverse colon, descending colon, and
Uh,
sigmoid.
Whole of
With
sigmoid? How do you decide the distal line of resection in a descending colon growth? Do you need to take the
sir,
whole of sigmoid
mostly
up to the retrocystic
5.
junction?
Sir, distal and proximal, the tumor distal and proximal should be minimum like 5 to 10 centimeter
See,
margin.
that you need not go even to the left hemicolectomy. You are doing left hemicolectomy for the vascular arcade.
Yes,
But
sir.
if you
yes.
talk of the
Yes.
distal clearance, you said whole
This
sigmoid. I do not agree with whole sigmoid
No,
because
it's not whole sigmoid.
yes, how much? What is the optimal line of clearance from the distal margin of the growth to the distal line of resection? It should be
10 centimeter.
little high. It should be 5 to 7 centimeter.
Okay.
Right, because
where
as you go down in the rectum, you keep on curtailing the clearance. So 5 to 7 centimeter distal clearance is good. So
Okay,
it
sir.
should be around mid sigmoid if you talk of a descending colon growth.
Yeah. Okay, sir.
And what else you remove with
which
this? Apart from this gut,
Yes, sir. What else?
what else you remove with this specimen? It's a
Okay.
radical
Lymph node.
left
So
hemicolectomy.
lymph nodes
Can you tell us
along the alcoholic
what are the
vessels.
different lymph node groups in relation to the colon?
So it is epicolic, paracolic, intermediate, and principal group of
Very good,
lymph nodes.
very good. So this is
Ep
the other distinct group of lymph nodes. You should take care during doing a radical hemicolectomy in malignancy.
yes,
and
sir.
you should also say that I would include the mesocolon also because
Yes,
you
sir.
have to remove
Mesocolon.
the peritoneal coverings starting from the the point where you ligate the main vessel. If you are ligating inferior mesenteric artery from there
Yes, sir.
onwards, entire mesocolon has to be removed, taken out with the specimen,
Yes,
isn't
sir.
it?
Yes, sir.
Uh, how many lymph nodes should ideally be removed in your specimen for proper end staging?
Sir, 10 to 15 lymph nodes.
At least 12 lymph nodes should be
12.
should
12.
be examined by the pathologist to give you a proper end staging. Okay.
Okay.
And what, Sir Arkichu?
Okay. That should be the
And
objective.
after that, we can also give adjuvant chemotherapy.
Okay.
That wait, that is another point of discussion. So once you send the patient to the pathologist, what do you expect in the pathology report? What do you expect in the
Yes.
pathology report? Because that will guide you for your subsequent adjuvant treatment.
Yes, sir. Uh, uh, no, first the margins, where margins
No,
are
not
negative.
talk about the tumor itself. What is
Tumor.
this tumor? Tumor histology, grade,
Histology, great, yes, sir.
grade, and the other part of tumor analysis by the genetic study you have discussed. And
Yes,
now
sir.
talk of the margins.
Lymph
Lymph,
Okay.
nodes.
lymphovascular invasion, perineural invasion,
Yes.
Yes,
those are
sir.
also important
And
prognostic factors.
pathologist can tell you whether the tumor is growing outside the serosa,
Ulcerative.
because pathologist will give you another staging, P staging,
P stage. Yeah.
P,
Yes, sir. PT.
and then patient will have this lymph nodes being examined by the pathologist. She can give you the number of lymph nodes being metastatic or hyperplastic. Okay, so you need to review
Okay.
this. Why this is important to plan adjuvant treatment? You don't give blanket adjuvant treatment for all patients. What is the policy?
So mainly the stage one disease neoadjuvant is not required, but
Yes. What
for
about stage
stage
2?
2, stage 3, adjuvant therapy, chemotherapy is quite
But
beneficial.
at postgrad level, I will not agree that you straightway say stage 2 is always for adjuvant
Not
treatment. There is
always,
some
sir.
controversy. Yes.
Yes, sir.
Stage 2 is a gray
Controversy.
area.
Yes,
Stage 2
sir.
is a gray area. Do you know any recent advance, some investigation which can predict increased recurrence, which will dictate that even stage 2 should get chemotherapy? Any other study like breast?
Some trials.
Yeah, they have studied something and said that yes, the other patient who had high risk of recurrence and they should be given chemotherapy, adjuvant therapy even in stage 2. This is you can study the oncotype DX and something called coloprint, like print. They have
Mamma
some markers called
printable.
coloprint.
Yes,
So
sir.
if you have a patient who is high risk in view of oncotype DX study and coloprint study, then you can consider yes, even stage 2 patient should get adjuvant chemotherapy. Okay.
Okay, sir.
If lymph nodes are involved, you must give the adjuvant chemotherapy. If
Yes,
not,
yes.
if you find that the histology is not, bad, like for example, signet ring, poorly differentiated mucinous type of growth, those are the with lymphovascular invasion, perineural invasion. Those are the candidates, as sir was saying, the gray areas where there is a scope of adjuvant therapy, of course. Suppose this patient had come to you in the emergency with an obstructed left colon. Okay.
Yes, sir.
Fine. This will be the last question from my end. Obstructed. What are the options with you? As an emergency surgeon, you are operating. You find a obstructed left colon due to a growth, because that is one of the presentations, isn't it?
Yes, sir.
So, what will be the options with you?
Sir, I will do segmental resection and
No, you tell us
colostomy
what are the options. 1, 2, 3, 4, like that.
Okay, sir. One, I will do segmental resection and I will do colostomy formation.
What colostomy? End colostomy. You are talking about Hartmann's procedure.
No, sir, not Hartmann.
What is Hartmann's procedure?
Sir, removal of the colon till sigmoid colon and then proximal colostomy is done.
So resection, end colostomy, end proximal colostomy, and distal end is closed. Isn't it? And
yes, sir.
put and left in the pelvis.
Yes,
And
sir.
later on, it is reversed. Hartmann's reversal is done.
Yes, sir. This can be done also here.
Sometimes Hartmann's reversal is a bit difficult procedure, so some people try to avoid this difficulty by doing a
transverse colostomy.
No. By the same thing, instead of putting that thing down into the pelvis, you keep it as a mucous fistula as well. Yeah, that is a double-barreled colostomy. So either a Hartmann's procedure or a Paul Mikulicz type of double-barrel colostomy. This is one. Other can be just the patient's general condition is not very good. You can do a what? You can simply do a
colostomy.
proximal loop colostomy,
Loop, yes.
proximal loop colostomy, followed by at a later stage when the condition of the
We
patient
can
improves,
do
do a
definitive.
resection, second stage procedure resection, followed by anastomosis, and then finally a closure of the colostomy that you had already created at the first instance. So first instance, just do a colostomy, relieve the obstruction, then make the patient's general condition a little bit better, go for resection and anastomosis, and then you go for closure of the colostomy, three-stage procedure. This is second option. Third option can be, if you are
Sir, not, sir, I've just read about stents and all.
yeah, stenting is an option. Very good. So stenting is an option that can buy you some time.
But sir,
And
I've never seen, I mean, just read in the books. I've never seen, I
yes,
don't know.
certain things you have to read and say also, because theoretical knowledge is also important. And fourth option is you can go for, if you think that the condition of the patient is good enough, you have got a good anesthetic backup, you've got a good suture materials, antibiotics, you can go for primary resection and anastomosis.
Primary closure, yes.
Resection and follow along with the, of course, a proximal loop ileostomy. Isn't it?
Yes,
that
sir.
is another option. Sir, anything else?
Yeah, Alkama, do you know what is at one time is a popularized SCOTIA approach, SCOTIA? What is SCOTIA approach for such obstetric lesion?
Sir, could not hear you properly.
What is SCOTIA approach? This is subtotal colectomy, on-table irrigation, and primary anastomosis. That was the approach advised for obstructing carcinomas. Because if you do a hemicolectomy, the colon is already distended. It's difficult to make a primary colocolic anastomosis. So in such situation, you can do a subtotal colectomy and do a ileosigmoid anastomosis.
And then later anastomosis.
One-stage surgery. Okay, Alkama, I have an impression that I was going to the recent update. What is the difference in behavior between a right colonic carcinoma and the left colonic carcinoma? Are these two same disease entities?
No, sir. It is, sir. There are difference in presentation. There are difference in signs and symptoms. The type of
like
symptoms
what
they
is the
cause.
presentation difference? What may be the
Sir, right colon disease are mainly ulceroproliferative type, and left colon is mainly stenosing type. So right colon mainly they present with melena, obstructing features also, and left
features. Right colon obstructive features. No.
Left colon obstructive features. Right colon mainly melena.
It is now defined as a distinct, different disease entity. Right colonic carcinomas are more common in females. Right colonic carcinoma occur at an earlier age. Right colonic carcinomas are more associated with MSI. And left colonic carcinomas more associated with CIN, chromosomal instability. And the right colonic carcinomas are more commonly flat lesions. And left colonic carcinomas are more commonly proliferative lesions. Okay?
Sir, left colon mainly is stenosing type.
No. I'm not talking of stenosing. I'm talking of proliferative and flat. Right colonic carcinomas are not obstruction because they are more of flat tumors. Okay, left colonic carcinoma may be stenosing or a proliferative mass.
Yes,
and prognosis wise, what do you think? Right colonic carcinoma is better or left colonic carcinoma is better?
So right is better.
No. Left colonic carcinoma report, you see the overall survival, everything is better. Okay. And what about the treatment difference?
So right colon carcinoma, we will do right hemicolectomy.
No, I'm not talking. I mean, I'm talking of adjuvant treatment. So that will depend on your genetic study. Okay, genetic study. You said that this more immunogenic response is there in the right colonic growth. So right colonic growth are more amenable to treatment with monoclonal antibodies.
Rather than F5FU. Because microsatellite instability, patients with microsatellite instability do not usually respond to 5-8.
Okay, sir.
And left chronic carcinomas are more commonly being treated adjuvantly with the targeted therapies
Cetuximab.
like cetuximab, zimab.
Bevacizumab, yes.
So now it is said that they are almost a distinct disease entity between the right and the left chronic carcinomas. And your approach is good. Dr. Acharji is online? Dr. Acharji? Dr. Acharji is online?
Yes, yes.
Yeah,
Yes,
Dr. Acharji, you can make a comment.
thank you. Professor Shah and Prashant, thank you.
Thank you. Thank you.
It's a very good coverage, but in connection with your last question, that the patient presenting with acute obstruction in good centers, I would think of another option, and it has been used for some time now. That is emergency endoscopic laser canalization of the obstructive tissue.
Yes, that's right.
That is a very good option. I've seen patients.
Yes, instead of stenting, laser boring.
Yeah. That is a very good option. Patient, this is not curative, but the patient obstructive lesion is gone. The patient improves and buys time for preparing the patient for a definitive radical surgery. That is one. And one thing for the student, Hello?
Yes, sir.
Hello?
No, somebody has unmuted his mic, that's why.
For the student, I just want to point out one thing. There's some difference between a colectomy, whether it's total left or right or extended or whatever. When you are doing a lymph node, it is better to add the adjective radical before it, radical hemicolectomy or radical right hemicolectomy, which means that you were also taking out the lymph nodes also. The difference between a benign colectomy, whatever colectomy, for a benign disease and a malignant disease is that you were removing along with this tumor or obstructive lesion or whatever, along with this you were removing lymph nodes also. And the adjective, use of adjective radical means that also.
Okay, sir.
Okay, Alkama, you have answered very well.
Thank you, sir.
The presentation is good, and you should read some recent advances on the management of these chronic malignancies. Otherwise, you answered very well. Dr. Bhattacharya, any last minute comment?
No, something very, very nice. I think she should be congratulated for the nice presentation.
Thank you, sir.
Thank you, Milind.
Thank you.